Good morning. Thank you for joining us today. I'm glad to be here to talk with you about cognitive rehabilitation. Today's presentation has a lot of people on from a wide variety of backgrounds, and so I hope that I will be able to provide some information that will be helpful to each of you. It is 101, Cognitive Rehab 101, so a little bit of a kind of a basic overview. We're going to talk about what cognitive rehab is, who is the recipient of cognitive rehab, where cognitive rehab takes place, who the providers are, and then cover a little bit of information about some of the cognitive rehab strategies. And so just to begin, really we have to talk about cognition first. When you talk about cognitive rehab, of course, you have to understand what cognition is. Cognition is defined as the mental action or process of acquiring knowledge and understanding through thought and experience in the senses. It's the processes of knowing, including attending, remembering, and reasoning, and the content of the processes, things like concepts and memories. That's the American Psychological Association definition. And again, it encompasses knowledge and attention and memory, judgment, reasoning, comprehension, language. Without cognition, we can't use existing knowledge and generate new knowledge. These are internal mental processes that we can assess or test these with behavioral methods, but they're really not directly observable. The physical mechanisms of cognition involve the formation of connections between neurons in the brain and then the sending and receiving of signals between connected neurons. So then any factor that interferes with those processes create a barrier to cognition, and it's what we would refer to as a cognitive deficit. These are skills, cognitive skills, are skills that can be lost or can be altered due to brain damage that results from disease or injury. Cognitive functioning difficulties that are a result of disease or injury then often affect behavior and the ability to complete everyday tasks. And where other healthcare areas focus on prevention and treatment of disease, rehab broadly focuses on the enhancement of human functioning and the quality of life. There is, of course, a connection between disease or injury and that ability to function. As I said, sometimes or often a disease is cured, but a disability may remain, the disability that was created by or caused by the disease. At times, a disability can be reduced even in the presence of a disease or permanent injury. Many people think of rehab as concerning improving only physical disabilities, but of course rehab's not really limited to that at all. Cognitive rehab attempts to enhance functioning and independence in adults with cognitive deficits or impairments, again, that are the result of brain damage or disease, things that really commonly follow injuries like traumatic brain injuries or stroke. So let's see, let me go on to one of the definitions of cognitive rehab, and there are many for a number of reasons that I'll talk about too. But the Brain Injury Interdisciplinary Special Interest Group, which is part of the American Congress of Rehabilitation Medicine, has the most commonly referenced definition, and it is interdisciplinary. It's a systematic, functionally oriented service of therapeutic cognitive activities based on an assessment and an understanding of the person's brain behavior deficits. This is a definition that really allows for comprehensive interdisciplinary rehab programs with interventions to restore or reorganize function, to compensate for impaired function through new cognitive patterns or external devices, and to enable individuals to adapt to their new level of functioning. So cognitive rehab therapies may target specific cognitive domains like attention and reasoning and planning and memory, like we're going to talk about, and it is delivered in various contexts that we'll also talk some about. This is the definition according to one large insurance company, and I put this in here not because we are going to talk about insurance or reimbursement, but just to point out that insurance and the healthcare system really does kind of drive a great deal of the variables around the delivery of cognitive rehab in the United States. And so for providers of cognitive rehab, it's always important to make sure that you know what the requirements are, and that would include the various definitions. And the point that I want to make here is that this insurance company's definition requires these things. So all of the following here, all of the following are met. Number 2, the cognitive deficits have been acquired as a result of neurologic impairment due to moderate to severe traumatic brain injury, brain surgery, stroke, or encephalopathy, of course, other conditions. But the point that I want to make about this is that Aetna, I'm sorry, I was going to not tell you which large insurance company that was. This insurance company considers cognitive rehab experimental. Many do, actually, not just this one. For other indications other than those that are the result of a traumatic brain injury, surgery, stroke, or encephalopathy. So for treatment of things like seizure disorders, learning disabilities, cerebral palsy, memory deficits that are due to other kinds of things, it is not indicated at all by many insurance companies. So we're kind of going to stick today to the definition that would encompass those major causes of brain injury. And first, a little bit of information about the history of cognitive rehab. It's pretty much, the field of cognitive rehab has developed alongside wars, at least in the early stages. World War I and post-World War I, advocates for soldiers with head injuries really did feel that they could be rehabilitated. There was some different opinion about the strategy to be used, with some recommending remediation and others recommending direct vocational training, which was, of course, largely the focus of rehab, both World War I and World War II. It was the return to work idea. Post-World War I, there was the introduction of functional skill building for injured veterans, and there were actually some schools for soldiers that were considered rehab hospitals, especially in Germany. There were some German rehab hospitals, and they involved psych testing and measurement of concrete skills. They really did not emphasize things like attention and concentration and memory training like we do today. In the United States, there really was not much attention to this area at that time. There was one hospital in New Jersey in Cape May, the Hospital for Head Surgeries, and they provided some incidental rehab, mostly by involving patients in doing everyday tasks around the hospital, but not directly training in cognitive rehab. During World War II, there was an increase in the interest in cognitive rehab, and in England, there were brain injury centers that were opened in Oxford and Edinburgh after World War II. Neuropsychologist Oliver Zangwill, who later founded INS, developed an approach that utilized mostly skill-specific training and then also focused on training for specific abilities in certain conditions. He really thought neuropsych tests were helpful for detecting non-obvious impairment, but not as helpful for predicting vocational or school outcome. He thought it was better to use neurobehavioral task analysis for these purposes. And then post-World War II, there was the continued use of rehab strategies in multiple countries. It began to spread, again, largely around the treatment of soldiers with brain injuries. In Russia, Alexander Luria's work rehabilitating soldiers on a neurosurgical unit in the Ural Mountains led to the development of the theory of functional systems. He assessed neurocognitive functioning and the use of various adaptive mechanisms, and then identified the patient's spared skills that could be used to avert deficits and help build strengths. He proposed 3 functional units in the brain that had to work in concert with each other for normal cognitive functioning. And then, that's really kind of where that integrated view of brain functioning that we have today came from, rather than just focusing on localization. And Luria developed this 2-pronged strategy of cognitive rehab. Actually, we're going to talk a little bit more about that in a bit. But the goal at that point was, with Luria, was to strengthen spared skills and teach compensatory skills, and that is still used today. That's one of the the focuses, or one of the areas of focus today. In the U.S., cognitive rehab at that time began to occur under the guise of nervous and mental re-education. It was really developing out of psychiatric influences that were growing at the time as well. But psychologists and speech-language pathologists were spearheading treatment at that time. And then after World War II, that kind of work really did slow down again considerably. Today, of course, we're doing a great deal of work with patients who've had head injuries and blast injuries, and we're learning that the brain doesn't even actually have to be struck to experience an injury. Since the 70s, there's been a big increased attention in the United States to head injuries from things like car accidents and sports injuries, more in the last couple of decades. We're learning more about trauma in general, increasing our attention to prevention and education efforts. If you look at what's going on in car manufacturing, just the kinds of adaptations and features that are available in cars, and with the coming, and I guess already here, self-driving cars, this has created a lot more awareness about the impact of injuries. Sports and recreational head injuries, of course, have been there's been a tremendous increase in looking at those and the impact of those. The first acute rehab programs in the U.S. just for head injuries were in 1975, and growth has really continued tremendously since that time. Differences across the definitions of cognitive rehab and cognitive rehab therapies are based on theoretical differences regarding the underlying cognitive mechanisms that result in behavioral changes. The Brain Injury Association of America, which is the largest U.S. advocacy organization for individuals with brain injury, points out that these theoretical models vary along several different dimensions, some of them being the treatments. Treatments may be process-specific or focused on improving a particular cognitive domain or aimed at improving performance of particular activities. Sometimes the overall goal is to restore function in a cognitive domain or a set of domains, or in other times it's to teach those compensatory strategies. And so a range of therapies have been developed. Most U.S. cognitive rehab has been based on models of physical rehab, first begun around the treatment of polio, with the theory being that if the muscle's weak, you exercise it, it gets stronger. So if the brain is exercised, it's going to grow and develop like a muscle. But that's really kind of an inadequate assumption for brain cells. Brain injury results in neuronal cell damage, and that means that those cells are permanently damaged or gone, permanently affecting their previous function and associated dysfunction, and that compromises overall brain integrity and affects basic information processing and higher cognitive functions, especially executive functions. So unless other healthy cells in the region can be trained to take over the function of these damaged cells, the cells that are damaged in in brain injury, if they are killed, they do not regenerate. If those brain cells die, they don't regenerate. So the idea of cognitive remediation comes from the word remedy, which means to cure. That sometimes gives people kind of the idea that cognitive rehab can cure brain damage. But what we know about brain cells is that they're really different than skin cells or muscle cells, and they don't regenerate like other cells in the body if they have died. So we talk about cognitive rehab or retraining instead of remediation. Let's see, cognitive psychology. It was during the 70s and 80s that rehab researchers and therapists really became interested in cognitive psychology here in the States, and cognitive psychology had gone through a period of rapid growth in the 60s, and it was greatly impacted by the study of neurocognition and the treatment of cognitive impairments, and so new rehab techniques began to be studied to address cognitive impairment at that time. Another consideration is that a lot of the theories behind interventions are driven by deficits. So they're focused on improvement of specific isolated cognitive deficits without really understanding how that deficit could improve. So, more than thinking about just things like exercise theory, we have to also consider compensation theories. that what we're really doing is training the remaining intact neural pathways to take over the function of some of the damaged pathways in order to improve the function of the cells and in everyday life. Repetition alone doesn't bring back dead cells or make living brain cells do what the dead brain cells did. So there has to be a theoretical framework for kind of understanding how information processing and executive functioning and things like that can improve. There are some noteworthy barriers to or difficulties with research in this area, namely just the complexity of the brain, the individuality of brain development, brain function, and then of course the individuality of any brain injury. And then there's some methodological difficulties as well that we don't have time to talk about today, but just things like the difference in types of studies and research designs, and it's difficult to design a research study with matched control and experimental groups when you're considering brain functioning. In the past, though, the prognosis for recovery after brain injury really wasn't all that great. There just wasn't very much understanding of the brain's ability to recover. There was little expectation that patients would recover full function, and little understanding or practice of cognitive rehab strategies. And patients were kind of on their own largely, and recovery was left to chance. But we really have learned a lot. We understand much more about the brain's ability to recover. Cognitive rehab has become much more common, and patient outcomes have improved significantly. So looking at some of the cognitive deficits, the causes of cognitive deficits, I'm going to focus just a little bit on causes that are lasting, brain injury, stroke and TBI, and neurological disorders. And we're going to talk just briefly about those, not much at all about the temporary causes. So cognitive deficits themselves usually affect specific cognitive functions. You can see some of those here. About 80% of people with deficits due to stroke and TBI will also have an attention deficit or will have an attention deficit. About 65% will have a memory deficit. About 75% will have executive function deficits. But most of you probably know that attention, memory, and executive function are the most common cognitive deficits, no matter the cause. If you look at the functional areas of the brain, this is a little bit of a simplistic view, I know, but it is kind of an easy to understand one. The brain is not quite that simple at all. But each of the cognitive functions is associated with a particular area of the brain. That is not to say that it's confined to that area, but it's associated. So here you can see, if you look at, for example, the frontal lobe, you've got thinking and planning and problem solving and decision making, which we refer to as executive function, largely. This area is also responsible for impulse control or response inhibition, as it's often known. The temporal lobe is where you will find, not all of, but a lot of memory and speech, hearing, facial recognition. In the occipital lobe, the rear of the brain, there's vision, the processing of visual information. The parietal lobe controls perception, classification of objects, spelling, number recognition, VisuoSpatial Processing. What I haven't shown you here is where attention is, and that is because it's pretty much everywhere. If you were to mark up the attention areas of the brain, it would be in all of those lobes. The same functional areas are found in the right hemisphere, even though I'm just showing from the left side here. Generally speaking, both hemispheres perform the same cognitive functions, and they usually share the workload. There is sometimes some specialization on particular tasks. Again, there's a lot of different diagrams of the functional areas of the brain that you can find. And really, if you wanted a more realistic diagram, it would look more like this, with each area of the brain that talking back and forth with multiple other areas to perform a single function. If you tried to follow one of those, you would have to untangle it all over the brain. It quickly becomes so complex that it's really difficult to talk about it like that, which is why people use a more simplified model to show the brain. So back to the causes of cognitive deficits quickly, just looking at stroke first. A stroke is defined as the sudden damage or death of brain cells due to a lack of oxygen, which is caused by either a blockage of blood flow or the rupture of an artery to the brain. There's two types of strokes. Like I just described, one is when the blood flow is blocked, and that's called an ischemic stroke, and it really depends on the location of the blockage the damage does. It can affect either a very local area or it can affect a more broad area. If it's in a small artery out towards the end of the network of arteries, it's going to affect a small localized area and maybe only one specific cognitive function. But if it's in a larger artery, it's going to affect a broader area, and that then can affect multiple lobes of the brain and therefore multiple cognitive functions. About 88% of all strokes are ischemic. The other 12 are hemorrhagic strokes, which is when an artery ruptures in the brain, and those really do tend to affect a broader area and then, of course, impact multiple lobes and multiple cognitive functions. A lot of factors, of course, impact the amount of damage, including, the time between the beginning of the stroke and medical attention, and a number of other factors. Here that slide is. Sorry, the duration of the blood flow interruption determines how severe the cell damage is, as you can see. Okay, so at about 90 days, prognosis. About 60% will still have mild impairment, while almost 20% will still have severe impairment. The mortality rate at 3 months is about 15% for those with strokes. The major risk factor for stroke is age. Of course, if you think about the aging population right now, you can extrapolate that there's going to be, that we expect, an increase in numbers of people who have strokes. So looking at TBI injuries, traumatic brain injuries next, those are defined as the sudden damage or death of brain cells due to a violent blow or jolt to the head or by an object penetrating the skull. TBI is the leading cause of death for anyone under the age of 45. The damage here is caused by bruising, hemorrhaging, or stretching of brain tissue, stretching and tearing of brain tissue. And TBIs can be global. They can affect multiple areas of the brain and multiple cognitive functions. And then there can be injury to areas opposite from the area of impact, as you see pictured here. And these are called contra-coup injuries, so the opposite side when the head bounces back, or the brain bounces back inside the skull. In the United States, the leading causes of TBIs are motor vehicle and pedestrian accidents by far. They account for approximately 50% of such injuries. Falls are another leading cause. They contribute to 20% of all TBIs, and then things like gunshots and assaults and sports and recreational accidents are the next most prevalent. Okay. This is, again, just about the incidents. They're pretty common, unfortunately. Many go unreported and don't receive medical care. And about 52,000 people a year die from TBI, which you can see. And then a lot of the survivors of TBI, as many as 50%, have moderate to severe disabilities after. There's an estimation that over 5.3 million people are living in the U.S. today with permanent disabilities as a result of a TBI. And then the chances of suffering a TBI are increased pretty dramatically if that individual has a history of any prior head injuries. So after one TBI, the risk of a second injury is 3 times greater than it is for those who haven't had a prior TBI. After a second TBI, the risk of a third injury is 8 times greater than for someone who's not had a prior TBI. So it's a pretty significant risk. So looking at neurodegenerative diseases, here just the multiple sclerosis and dementia, both of these result in a slow decline in cognitive function. These are different than an injury. There's not a specific focal point. Again, although I've told you that the injuries can lead to pretty diffuse damage, there is a point of impact, and that's not the case with the neurodegenerative process. There's about 400,000 MS patients in the U.S., which is a lot, but the real big problem, as you see, is dementia. There's currently around 5 million cases. I think that may actually be higher now in 2017. The number one cause of dementia is Alzheimer's, and the predominant risk factor for Alzheimer's is age, just like with stroke. And of course, because we're aging rapidly as a nation, the number of dementia patients is also expected to actually double in the next 15 years. So cognitive deficits here with these kinds of diseases have a significant negative impact on activities of daily living and on quality of life, memory and planning problems and things like that. I'm going to talk a little more about that in another webinar later in the summer, where we're going to talk about cognitive rehab with older adults. But I can't talk about it overall without mentioning neurodegenerative diseases. Okay, so looking at cognitive rehab and beginning to think about restoring cognitive functioning, what do we do about these deficits? I mentioned earlier that we kind of thought during part of the 20th century, most of it really, we thought that brain structures were fixed, that they were pretty solidified after a critical period in early childhood. And after that period, if you experienced a brain trauma, it was just assumed that you would have to live with the resulting cognitive deficits. But in the last few years, researchers have shown that the brain's physical structures and functional organization can and do change in adults as well. This concept is called neuroplasticity. It's the brain's ability to remold and rewire itself. It's a response to changes in behavior, environment, thinking, or emotions. And one of the keys to restructuring is repetition. So you'll hear a lot of that in some of the strategies that when you are involved in cognitive rehab in any way. It's really the science of how the brain changes its structure and function in response to input. So the brain is designed to grow new structures and create new pathways in the presence of damage or an environmental challenge. And so rehab helps to change the brain and increase a person's function and skills. This is an idea that was first proposed in 1890 by William James, but it was an idea that was largely neglected for about the next 50 years. And then again, during the 20th century, we really thought that the lower brain and the neocortical areas were immutable in structure after childhood, and that the adult brain was hardwired with fixed neuronal circuits. But we've really challenged that now by new findings that suggest that all areas of the brain are plastic even after childhood. So this neurogenesis, the birth of brain cells, occurs in the adult mammalian brain even into old age, which has been a surprising finding for a lot of people. And a surprising consequence of that is that the brain activity that's associated with a given function can be moved or can move to a different location. So this can result just from normal experience, but it can also occur in the process of recovery with cognitive rehab after brain injury. Again, neuroplasticity being that fundamental issue that supports the scientific basis for treatment of acquired brain injury with goal-directed experiential therapeutic programs in the context of rehab approaches. It's been an exciting development. It's interesting to read about. So recovery of cognitive functions then can be aided with cognitive rehab therapy, which is defined here as a therapy program to help cognitively impaired individuals restore normal functioning or to compensate for cognitive deficits. There's specific therapies in general that a therapist will design for each of the cognitive functions, some of course that cross-function. Let's talk a little bit about how those cognitive functions are restored. One way is restitution, that is the reestablishing and strengthening of damaged neural pathways. This is a healing process. It applies in situations where neurons are damaged but not dead. This could be from short-term ischemia or pressure damage from a hemorrhagic stroke or from that stretching or tearing caused by a TBI. So again, neural pathways that are damaged but not dead can be reestablished and strengthened. And then another way is reorganization, and that is developing and strengthening new neural pathways. And this is the neuroplastic process, which can involve a slight detour to go around a damaged area, or maybe a total reassignment of a cognitive function to a completely different area of the brain. And then another way of recovering, I guess the last way I'm going to talk about right now is compensation, and that's the use of new strategies or things like external aids. So, some of the common kinds of those would be memory strategies or notes or day planners, things like that. In terms of practical therapy, there's not any difference really between restitution and reorganization. Whether the old neural pathways are being repaired or new ones are being built, the results are really the same. The neural pathways and the cognitive function is restored. Compensation, on the other hand, is used to deal with existing cognitive deficits without restoring the neural functions. Let's see, what else do I want to say about that? Let me move on to just covering the domains really quickly. I'm not going to go in depth about these, but just wanted to include them. There are several different components of attention. You can see them here. Alertness, of course, being primary. That includes tonic alertness, which is kind of an overall general level of awareness, and phasic alertness, which is the ability to increase your level of awareness with cueing or with a warning stimulus, like when somebody says, hey, pay attention now. Selective attention, which is the ability to focus attention onto particular stimuli while ignoring other stimuli. Sustained attention or vigilance is just what it sounds like, and then maintaining attention on a stimulus or task. VisuoSpatial attention is the ability to change the attention focus from one stimulus to another. Divided attention, the ability to focus on two or more stimuli at a time. Normal activities require specific components of attention, and one or more types of attention is really necessary for pretty much all of the activities that people enjoy. Selective attention provides the filtering that's required for speech recognition, which means it's necessary for socializing. Focused attention is needed for reading or hobbies. Sustained attention is required for understanding the content and the context of movies or TVs or books. Shifting focus is required for crossword puzzles or other hobbies. You can imagine how a disturbance in attention affects a patient's quality of life. The next cognitive function I want to look at quickly is memory. The practical definition here is just the ability to encode, store, retain, and subsequently recall information and past experiences in the brain. Memory is necessary for learning. It's necessary for all activities of daily living. It does affect all other cognitive functions. It affects any cognitive rehab that's undertaken. And it is the third most common deficit in people who've had a stroke or TBI. Working memory deficits have significant impact on overall cognitive skills. In addition to just generally forgetting what you were doing, deficits here also can affect things like problem solving and reading comprehension and calculating, reasoning, verbal comprehension. Let's move on to executive function, which we're defining as the coordination of multiple cognitive functions to produce a coherent, goal-directed result. It's kind of like the quarterback of the team. The executive functioning assigns cognitive tasks to attention and memory and language and emotional centers and visual spatial processing. The executive then coordinates all of that activity with the purpose of achieving a specific goal. Executive functioning is necessary for purposeful behavior. It's necessary for all activities of daily living. It directs all other cognitive functions. It affects all cognitive rehab that's undertaken. It's the second most common deficit after a stroke or TBI. We know that 3 areas of the frontal lobe are necessary for various executive functions. I'm not going to go through those specifically here, but the dorsolateral prefrontal cortex, the orbitofrontal cortex, and the anterior cingulate all are involved in things like information processing, affect, impulse control, motivation, decision-making, risky behavior, emotional outbursts, things like that. All three of those areas really have one function in common, though, and that is response inhibition and impulse control. So again, you can kind of think about how damage to areas that affect executive function affect somebody's day-to-day life. And once again, a little more realistic diagram of executive functions would look like this, with signals to and from many other parts of the brain. Even this is extremely simplified. But they show those basic concepts, really, that those frontal areas that are affected by executive function really don't act alone. They're essential for all of the executive functions. And damage to each of the prefrontal areas can cause a fairly predictable set of specific executive deficits. Deficits in the areas that affect executive function are often underestimated or not perceived by a patient, and they're very, very difficult for family members and friends to understand and deal with. They cause a lot of problems with family and social and work reintegration, which of course are some of the most common long-term effects of brain trauma. And only some of those are amenable to cognitive rehab. Attention, of course, is, and working memory and problem solving, as well as decision-making skills. But social and emotional dysfunctions are less amenable to cognitive rehab. They can be addressed with behavioral or other types of intervention, however. And then visual-spatial processing. This is defined as the analysis of complex visual stimuli which allow us to perceive whole objects and the spatial relationships among them. So this gives us an idea of what it is, but you really also have to say what it's not, and that is visual spatial processing is not vision. It's not the visual field. It's not the function associated with hemianopsia, neglect, or saccadic movement. It's not visual attention, the ability to focus attention on an object in space. Visual spatial processing is that cognitive process of visual information that allows you to see objects in their entirety and understand those spatial relationships between the objects. It's our predominant method for processing information about the world around us. It's subconsciously driven, so it's difficult to explain, really. It affects other areas of cognitive rehab, of course, when you're conducting cognitive rehab with visual spatial processing deficits. It does affect all areas of activities of daily living. Let's see what we want to say about that. So in addition to interpreting visual cues such as size and shape, there's other visual spatial skills associated with objects, like separating objects from a background, identifying an object when only part of it's visible, being able to form a mental image of an object, and then spatial skills, which of course include things like depth perception, assessing if an object is vertical or horizontal, mental rotation, both two-dimensional and three-dimensional, and forming mental maps. And then visual constructive skills, which include copying a drawing and assembling 2 and 3D objects. The drawing on the lower left is from a patient with a visual spatial deficit. You can see that only the right part of the drawing is present. So this really requires processing, reading. If you think about the visual spatial abilities that are involved in reading, they include processing shapes and positions. You need depth perception in order to just pick up a simple object, to drive. Orientation and navigation in the environment, of course, require mental mapping. Interpreting angles is necessary for reading a clock. Mental imagery in 3D are needed for pretty much, for dressing and for a whole lot of activities of daily living. I want to talk about the visual field quickly. It's not a separate area of it's not a separate cognitive domain, but I want to talk about it because it is often a focus of cognitive rehab. Basically, it's that spatial array that's visible to a person without looking around. So if you look straight ahead, excuse me, all of the area that is visible in your peripheral vision and your the vision in front of you would be considered your visual field. So a visual field deficit is a loss of a portion of that. And I'm talking here about neurocognitive visual field deficits, so those that are caused by brain injury, not an eye injury. deficits in the visual field are pretty common after strokes, especially ischemic strokes. Actually, I think only ischemic strokes, or maybe just mainly ischemic strokes. But about 45 to 65% of people who have ischemic strokes have deficits in the visual field. But the recovery of that pretty quickly is common. Only about 8 to 25% have long-term deficits. They're pretty or relatively uncommon after TBI, at least comparatively to strokes. But TBI patients often do have ocular or ocular motor problems. And there is some concern, though, that visual field deficits are significantly underdiagnosed in the TBI population. We always heard that the occipital lobe is the vision center of the brain, but other areas of the brain are involved in vision too, especially the posterior portions of the parietal lobe and the temporal lobe. Patients are often unaware of visual field deficits. They may notice the consequences, of course, or their caregivers may notice it. They may bump into things or even people. Patients often blame these problems on other causes, like poor lighting. And if they do recognize that they have a visual field loss, they often do think that it's a visual problem rather than a visual field problem. So here's a couple of pictures from a study by A.M. Hoste. They were edited here to illustrate the study's findings that defects are not perceived as black clouds. If you look here in this person's field of vision, you see the black clouds. The brain conceals those in patterns and colors of the surrounding environment. So this particular work was based on glaucoma patients, but stroke or TBI patients often report this same fill-in effect. We represent visual field deficits as black areas here on this graph, and then assume it's like the patient is looking through a window with that pattern painted in black, but the patient just doesn't perceive those areas. Let's see, I think I have. No, I don't have another example of that kind of defect, but this is another kind of defect that's often confused with hemianopia, and this is hemispatial neglect, which is also known as unilateral neglect or sometimes just neglect. And that is when the person, not consciously, but the person doesn't pay attention to, because they lack awareness of one side of space. It's an attention deficit. It is not a visual field deficit. So the left hemispace neglect is very common after stroke. It affects about 43% of patients with right brain lesions. Right side neglect is less common and less persistent. So I just pointed this out because, again, these are often areas that are affected by these kinds of injuries, especially strokes, and then are addressed in cognitive rehab. This is a slide that just shows some of the comparisons between hemispatial neglect and hemianopia. So who gets cognitive rehab? Let's see. The brain is really responsible for producing all forms of human behavior, but it's pretty fragile, and severe injury creates or can create pretty significant problems in behavior and adaptive functioning in society. After a severe traumatic brain injury, there are several common long-lasting deficits in functioning that can occur, and a lot of times individuals with severe brain injury are often unable to be an effective part of society. They have trouble with family and social relationships, and just fully participating in the life of the community. These are some of the common symptoms that you'll see with somebody who's got head injuries. Here are some physical characteristics of brain injury, which I'm not going through. And then some of the cognitive characteristics of brain injury, and they correspond with some of what we've been talking about: impaired attention and concentration, memory impairments for learning and recall, impaired problem solving, decision making, etc. Right? Those make sense given what we've just gone through about each of those different domains. Here's some of the behavioral characteristics. Again, I'm not going through these, but these often go hand in hand with some of the cognitive deficits and are addressed some in cognitive rehab, mostly as a result of cognitive rehab, but also in other behavioral treatments. So where does cognitive rehab take place? Who are the providers? Models of rehab in the past, really, they were largely provided rehab programs for people with brain injury have largely been provided in a medical model, and this really is still the predominant model, but the trend is a little more towards community and home-based rehab models, especially as the average length of stay in hospitals and rehab facilities continues to shrink or fall. The importance of community services grows. Most patients who receive cognitive rehab therapy do so as inpatients when their medical status has stabilized. Recovery and adjustment occurs over a trajectory of weeks, months, and years. Often rehab interventions really depend on the amount of time since injury onset. Few patients receive cognitive rehab therapy more than a year after injury, even though spontaneous neurological recovery will have slowed by this time. Patients are more likely to have better awareness of their limitations and ability by that time. The timing of cognitive rehab therapy really is dictated a lot by health insurance and health payer policies, not as much by when the patient would benefit most. The effects of TBI occur across time rather than, for example, an injury, which may be a single discrete event. So deficits associated with brain injury may really require treatment throughout the patient's lifespan in some cases. New cognitive rehab treatments may be required as they have changes or transitions in life. Treatment approaches, though, include comprehensive inpatient or outpatient cognitive rehab programs, outpatient cognitive rehab delivered by a sole practitioner, or more frequently, comprehensive cognitive rehab programs with multiple providers working together on a team. There is some debate about when and where to deliver cognitive rehab. Some advocate for really early intervention. Others call for intervention at more chronic recovery stages. There's a lot of thought that cognitive rehab should be provided at every stage of rehab, from coma to community, as appropriate to the needs of the individual with the brain injury. And you can see here some of the different levels of care. Of course, people begin assessing cognitively even with emergency medical treatment in the ER, and then of course there's surgery and intensive care and maybe a neurological unit, and then inpatient care where certainly there is cognitive evaluation in the beginning of a more focused treatment, cognitive rehab. It's common here to aim to increase attention and learning and basic communication skills, depending, of course, on the injury. There are some comprehensive inpatient programs that are specifically designed for patients who have severe cognitive impairments. And then outpatient care, of course. As I mentioned, most people with TBI continue to need cognitive rehab long after inpatient rehab ends, and those programs have really grown tremendously. There's also acute inpatient rehab units, as I mentioned, just focused specifically on, and then post-acute residential facilities at times are necessary. Okay, so it's really, 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 really important that cognitive rehab be delivered in a multidisciplinary context, not as a function of as a standalone therapy. The very first member of the multidisciplinary team, of course, has to be the patient, him or herself. They really have to be involved with the cognitive treatment endeavor. They need to endorse the rationale for the plan. They need to understand the methods and materials used for cognitive training and accept the need for engagement. And, of course, much of that changes as time goes by and the patient has cognitive improvement. But patients who are active participants in the goal setting and process monitoring really demonstrate superior goal attainment and maintenance in cognitive rehab. It's also incredibly important for the therapist to know the patient, to know who they were before the injury, what their personality was like, their life roles, their hobbies, their social life, etc. All right, I'm going to start moving faster. So I mentioned how important this wait, hold on, time out. Okay, one more slide, sorry. Okay, who are the providers? So you guys know who these people are. I don't need to explain what these guys do, these particular types of providers. But because of the breadth and the complexity of problems following TBI, there are many, many different types of medical professionals who become involved in the direct care of a particular individual. And they may be involved, more at one time than at others. But these are some of the common types of providers. Okay, I have several slides through here that are in your handout that talk some about those types of providers. So again, I'm going to just skip through those to get to families. I want to make sure that you see that. The role of families is incredibly important. It is almost as important as the involvement of the patient themselves. For those who have any sort of a family or support system, they should play an important role as well and be actively involved. Looking at some of the strategies, the goals of cognitive rehab are, of course, as I mentioned early on, to enhance capacity to process and interpret information and to improve the ability to function in all aspects of family and community life. Restorative training may focus on improving a specific cognitive functioning, as I mentioned earlier as well. Remember that compensatory training focuses on adapting to the presence of a cognitive deficit, which may have restorative effects at certain times. There are cognitive rehab programs that rely only on a single strategy. Others use an integrated or interdisciplinary approach. There's some broad differences across programs and treatment strategies, but goal-oriented cognitive rehab interventions really aim to draw on the retained strengths to support adaptive behavior and achieve optimum levels of well-being by targeting performance on personally relevant goals. Some of the components, again, these I mentioned early on as well, restorative and compensatory, and I went through those earlier, so I'm not going to go back through those right now given our time. Let me make sure I'm not missing something really important that I want to say about those. They aren't mutually exclusive. I guess that's one of the things that you should know. They should be undertaken basically at the same time. Treatments that attempt to restore lost function should be undertaken at the same time as teaching compensatory strategies. Sometimes the compensatory strategies are easier. They require less cognitive load to work on, and so that may be the place to begin. But again, you wouldn't want to do that exclusively. So there's some evidence that cognitive rehab can promote reorganization of memory function. We have clear evidence that internal and external compensations can be very effective at improving memory function, and that these improvements then transfer to things like activities of daily living. Executive functions appear to be amenable to all forms of recovery, all three forms here that you see. VisuoSpatial processing appears to be amenable to restitution, and there are compensation strategies there as well. There's evidence of reorganization of visuospatial functions to the contralateral areas of the brain. So if you are interested in a particular area or have a particular question about whether or not something is effective in a particular type of injury or deficit, you can probably find now research that's being done around that for most areas. Yep. Okay. Characteristics of cognitive rehab interventions are that they should be structured. This is basically from a consensus conference sponsored by the National Institute of Child Health and Human Development that concluded that these interventions should be structured and systematic, goal-directed, individualized. They should involve learning, practice, social contact, and relevant context, and be repetitive. This is an overall holistic model. It's very difficult to see on this slide. I get it. It's difficult to see in the handout. If you will look up at the very top, this is Barbara Wilson, 2002. You can Google and find this if you're interested in looking at it. But it makes the basic point that here is the patient right here. This is the patient and family in this box. And all of the other boxes and systems that you see around are things like neuropsych assessments, models of cognitive functioning, emotional and psychosocial models, behavioral models, behavioral assessments, how much recovery to expect. Oh, wait, I should back up to the current problem. Here's the premorbid personality and lifestyle. Here's personality assessments. Here's the nature of the brain injury. So a really holistic view of cognitive rehab, a very comprehensive model of and way of conceptualizing what cognitive rehab should be like. It's also recommended or considered that cognitive skills themselves can be considered as a hierarchy, with attention skills seen as the underlying foundation of all the other cognitive skills, and so assessment and treatment is recommended to always begin at this level if problems are evident, but always evaluating executive functioning and awareness. That should be worked on and evaluated at all stages. It's important always to determine whether things like, for example, memory difficulties are dependent on attention or information processing failures, or if they're secondary manifestations of things like impulsivity, attention deficits, or information processing failures, or the result of interactions among those functions, because things like that help you really prioritize the training. Again, those cognitive skill areas include executive function, memory, information processing, visual processing, and attention. And then some of the specific strategies. These are just examples of some. Process training, which stimulates poorly functioning neurological pathways in the brain in order to maximize their efficiency and effectiveness, really aiming to overcome the damage. Strategy training involves teaching compensation strategies. Things, again, as I mentioned earlier, using mnemonics that can't be observed, like visualizations and word associations, or more external things like alarms and notebooks and calendars and lists. Functional activities focus really on improving real-life functioning, used as a vehicle within which to treat the cognitive skill deficits and to train the person to complete a particular functional task. So that it begins with, the goals of the patient, or thinking about their goals that are valuable to them and important to their person and their life. And then it involves breaking down the functional activities into the component parts and then relating those to process training and strategy training components. Other cognitive rehab interventions, or many of them, are applied through technology and other compensatory strategies that allow the individual to accomplish important life activities and more fully participate. Cognitive exercises, including computer-assisted strategies, have been used, and their use is increasing, to improve specific neuropsych processes, predominantly attention and memory and executive skills. So computer-based tools include things like virtual reality, computer software that allows work on different cognitive abilities like visual memory, verbal memory, attention to visual objects, working memory, etc. Interventions in cognitive rehab are being developed rapidly. They've really only recently been subjected to scientific inquiry. So the efficacy of cognitive rehab so far has been measured by its objective influence on function and the subjective value of these changes to the individual. But you are able to find a good deal of evidence in the literature now, again, as I mentioned earlier. Here's a picture of some of the computer-assisted cog rehab domains and types of tasks. Okay, 2 minutes. Let's see. Somebody's asking about the types of software available, and I did not include specific instruments in this presentation. I will say that Pearson has instruments that are useful for across-the-board screening of cognitive deficits, and then a very specific cognitive rehab program that is computerized called REHACOM, REHACOM. That's available on the Pearson Clinical website if you want more information about it. And I'm saying that because somebody's asking that in the chat box. But again, this slide right here, will show you a little bit about the types of tasks that are targeted with computer-assisted rehab. It's not brain training. It is rehabilitation and focused on attention and memory and executive function, visual field, visual spatial processing, things like that, face recognition. Here is memory therapy. Again, not all on the computer, but certainly can be. There are a lot of different subtests and tasks that are available in computerized format, including in REACOM. Visual field therapy. There's evidence, again, for the effectiveness of this kind of training. This is a picture of hemispatial neglect that I just thought was really, really cool because it does show, this is an artist back in the 60s who had a stroke in 1967, and you can see that his awareness of his left hemispace increases over 8 months. I have no idea what type of rehab this person had. If you think about it being in the 60s, it probably was not an awful lot. But you can see the damage that was done 2 months after a stroke, and then the progress as he moves through, the 6 months, 8 months after the stroke. Here's some more examples of just specific strategies. Drill and practice, using repetitive practice to develop cognitive abilities, retraining, recall strategies like mnemonics and cueing and chunking and spaced retrieval, and then specific interventions, tasks that train on face name recall or number recall, story recall, things like that. There is evidence for cognitive rehab. This is a review article, a meta-analysis done by the Cognitive Rehabilitation Task Force of the, I'm going to blank on what this is, BIISIG. Yep, I'm blanking on the B. It's an interest group, special interest group of the ACRM, so the American College of Rehab Medicine. And they reviewed a bunch of Class 1 and Class 2 studies, Class 3 studies also, and overall found significant evidence to support cognitive rehab for attention, memory, executive function, visual spatial processing, all. Here are some practice standards from that article and some practice guidelines from that article that I included in the handout. So to conclude, cognitive rehab should be context-specific. It should include interventions and supports that are relevant to the routines of the person's everyday life. It should be collaborative between providers and patients' natural supports in everyday life. It should be collaborative with the patient who has the injury, offering choices and decision-making opportunities. It should emphasize strategy training to compensate for residual deficits, reduce disability and restore social role functioning, establish relevant and functional outcomes. It should not just focus on eliminating the underlying cognitive impairment. It's really directed toward improving everyday functioning, and it includes attempts to promote generalization or directly apply compensatory strategies in functional contexts. So it should concentrate then on long-term maintenance of improved functional outcomes and include continued support and intervention for patient and family. Okay, I'm at the end. Please email me with questions. I went a couple minutes over. I apologize. I appreciate very much you being here today to learn about cognitive rehab. We have more webinars in this series coming up, including some specific ones on a couple of the types of programs. Thank you.